Here we will summarize and highlight the comprehensive updates regarding non-muscle invasive bladder cancer. For classifying the grade of NMIBC, the guidelines recommend using both the 1973 and the 2004-22 WHO grading classification systems, or better, a hybrid system of the two, which has demonstrated better prognostic accuracy. There is significant variability among pathologists when diagnosing carcinoma in situ, with agreement only reached in 70 to 78% of cases. Additionally, the general agreement between pathology on staging and grading is only of 50-60%. Next, regarding photodynamic diagnosis, while some studies report a lower recurrence rates and improved time to recurrence with PDD, a large multi-center randomized control trial in the UK found that PDD-guided TURB did not improve recurrence rates or cost effectiveness at 3 years. Similar findings were found in studies assessing the efficacy of narrowband imaging. Regarding second-look TURB, a systematic review demonstrated a 51% of risk of persistence and an 8% risk of understaging for T1 tumors. Hence, a second TURB is strongly recommended when incomplete initial TURB or doubt about its completeness is present, or there is an absence of detrusor muscle in the specimen after an initial resection. The guidelines suggest performing a second TURB within 2 to 6 weeks of the initial resection. After resection, several prognostic models help stratify patients into risk groups and predict recurrence and progression rates. These are the 2006 EORTC scoring model, the Queto scoring model, the 2016 EORTC scoring model, which is particularly useful for predicting recurrence and progression in patients treated with 1 to 3 years of maintenance BCG, and finally the EAU NMIBC 2021 scoring model, which uses tumor stage, both histological grading systems, presence of CIS, tumor number and size, and the age to predict the risk of progression to muscle-invasive disease. It does not, however, predict recurrence in patients not receiving BCG. The 2006 EORTC model can be used for that purpose. It is important to note that this latter model does not consider factors such as urothelial carcinoma subtypes, lymphovascular invasion, primary CIS, or CIS in the prostatic urethra. It does not account for recurrent tumors, and based on current literature, patients with any of these features should be considered very high risk. Regarding disease management, some key points are counseling for smoking cessation, as this reduces the risk of recurrence and progression in NMIBC. Office-based fulguration is safe and effective for small, recurrent, low-grade TA tumors as an alternative to TURB. Secondly, when assessing intravesical chemotherapy post-TURB, a single immediate postoperative installation of chemotherapy, ideally within 2 hours of surgery, can reduce 5-year recurrence rates by up to 14% in certain populations, with low toxicity rates. In low-risk patients, a single installation is considered to be the standard for a complete treatment. However, for other risk groups, single installation is not sufficient due to considerable likelihood of recurrence. Indeed, repeat chemotherapy installations improved recurrence-free survival in intermediate-risk patients. However, the optimal schedule for further chemotherapy installations is not defined, however should not exceed 1 year. However, in intermediate and high-risk tumors, BCG immunotherapy is superior to TURB alone or TURB plus chemotherapy. Indeed, BCG demonstrated a 32% reduction in risk of recurrence when compared to mitomycin C. Regarding optimal BCG schedule, these are based on findings from the Nimbus trial, a Queto RCT, and an EORTC RCT. The standard induction schedule is 6 weekly installations. For optimal efficacy, maintenance BCG is important, with at least 1 year recommended to achieve superiority over mitomycin C, and 3 years of maintenance may further reduce recurrence in high-risk but not intermediate-risk patients. Carcinoma in situ cannot be treated with just an endoscopic procedure. After a diagnosis of CIS, further treatment with either intravesical BCG installations or radical cystectomy is necessary. Meta-analyses have consistently shown that intravesical BCG is more effective at treating CIS than intravesical chemotherapy. One meta-analysis found that BCG treatment resulted in a 59% reduction in the odds of treatment failure. Another found that BCG treatment resulted in a 35% reduction in the risk of progression compared with intravesical chemotherapy or immunotherapy. Next, defining BCG failure is important in identifying the optimal best next therapy. These are classified as BCG refractory tumor, where the tumors do not respond at all, BCG relapsing tumors, which is when the therapy responds but then relapses, BCG unresponsive tumor, which is a category created to better define the subgroup of patients for whom additional BCG therapy is unlikely to be beneficial. This encompasses the BCG refractory tumors, as well as those with T1, TA high-grade recurrence within 6 months of completing adequate BCG treatment, or those who develop CIS within 12 months of completing adequate BCG treatment. In these patients, radical cystectomy is recommended. Finally, we have BCG exposed tumor, which describes the high-risk group that falls between a BCG naive and BCG unresponsive NMIBC. NMIBC. These patients have experienced recurrence with high-grade disease after BCG treatment, however, do not meet the criteria for BCG unresponsive disease and hence may therefore benefit from additional BCG therapy. Regarding these subcategories, it is important to note that current definitions state that non-high-grade recurrence after BCG is not considered a BCG failure. Finally, regarding treatment for BCG unresponsive NMIBC, radical cystectomy remains the gold standard. However, alternative bladder preservation strategies are under investigation, including cytotoxic intravesical therapies, device-assisted installations, intravesical and systemic immunotherapies, and finally gene therapy. New immunotherapies show promise. Pembrolizumab has achieved a 40% complete response in patients with BCG unresponsive CIS, which was sustained in 48% at 12 months, leading to an FDA approval. Secondly, nadofaragene firadenovec showed a 53% complete response for BCG unresponsive CIS in a phase 3 trial. And finally, radical cystectomy remains oncologically superior for BCG unresponsive cases. However, for non-high-grade and some high-grade recurrences, such as those occurring 1 year post-BCG therapy, additional BCG may be beneficial.